Okay. So we have seen patients with meningitis. We all know the signs and symptoms they display. So now, what is meningitis? Now, meningitis is defined as inflammation of the meninges. So we all know the meninges because this is not anatomy class. So that is why I didn't bother myself to describe the meninges because there is no time for that. So can we respond? What is meninges? Let's respond. Meningitis is inflammation of the meninges. What are the meninges? What do we understand by meninges? Please let's respond. Let's type. Because of our time, let's explain. Let's respond. Okay, covering of the brain. Yeah. Yes. Thank you. Not just the covering of the brain. Meninges are protective covering. Thank you. So meninges are protective covering, protective layer that protects the brain and the spinal cord. So, and it is made up of what? Several layers. It has 3 layers majorly. Okay. So I usually give it an acronym DAP. The dura mater, the arachnoid matter, and the pia mater. So when we are talking about meningitis, that means it is the inflammation of the meninges. So the meninges that covers the brain and the spinal cord is inflamed. A microorganism has actually attacked that meninges, and there is inflammatory process going on. So that is why we call it meningitis. So there is inflammation of the dura, the arachnoid matter. So I want to take note that it is not the dura mater that is majorly affected in meningitis. It is the arachnoid and the pia mater majorly that is affected. So I hope you are following me. Please, does my explanation, does it make any sense to you? Are we still together? I can't see your response. Can I go on? Okay. So take a look at this diagram. I hope you can see it. Can you see a diagram, a slide? Someone say I should come again. We said meningitis is the inflammation of the meninges, and I asked the class that what is meninges? And people responded that meninges is the what? Is the outer protective covering of the brain and the spinal cord. So few people responded that it is the outer protective covering of the brain and the spinal cord. So when that meninges is inflamed or is attacked by a microorganism, be it bacterial, virus, fungi, protozoa, whatever, then we say someone has meningitis. And I said, okay, look at this diagram now. This is the diagram of the meninges. You can see we have the dura mater, the arachnoid matter. I told you that meninges is made up of this particular layer. The dura mater, the arachnoid, and the pia mater. So when we are talking about meningitis, the dura mater is not really affected. The part that is affected is the arachnoid, which is the middle layer, and the inner layer, which is the pia layer, the pia mater. So now you will notice from this diagram that if you look at the diagram very well, you can see that between the arachnoid and the pia mater, what can you see? If you actually understand this diagram, please let's respond. What can you see between the arachnoid and the pia mater? You can all see the diagram. Please let's respond. If you understand this diagram on the slide, what can you see? The diagram is well labeled. There is something between thank you, subarachnoid space. And please, nurses, what do we have in the subarachnoid space? Can you tell me? What do we have within this subarachnoid space? What is there? There's something there very important. Subarachnoid fluid, no. Thank you, CSF. Cerebrospinal fluid. So the subarachnoid space contains the what? The cerebrospinal fluid. And cerebrospinal fluid, what does it do? It protects the what? It serves as a cushion for the brain and the spinal cord. It prevents any form of impact on the brain, and it also nourishes it, like it provides nutrients for the brain, it provides nutrients for the spinal. So it's just like it's offering like a support, cushion, or protection. So I think it will make sense now if I continue. This is another diagram for you to have a better understanding. You can see that, okay, this is like a section of the brain, you know, the skull, it has been, you can see it's in section. So you can actually have a better view here. You can see the dura mater, the hypothalamus, the arachnoid, and the pia. So that's just for you to have a better understanding. So now, let's talk about examples of bacteria that can cause meningitis. Take note, it is not only bacteria that can cause meningitis. It can virus, fungi, protozoa, it can cause it. So but the most common one is bacteria. Please, let's take note. The most common one is bacteria. You can have, if a patient can have viral meningitis. So if your patient has meningitis, it's not in all cases that, okay, this meningitis is caused by bacteria. No, it can be caused by virus. Until when you do your lab investigation, that is when you will know. So when patient present with signs and symptoms of meningitis, it's not compulsory, or it's not all the time that it is caused by bacteria. It's caused by virus, it might be caused by protozoa, it might be caused by another type of organism entirely. So until you do the diagnosis, until they run tests on the patient, that is when they can know that, okay, is this meningitis caused by bacteria? Is it caused by virus? And that is what will help you in treatment. If it is bacterial meningitis, you know, okay, you are supposed to make use of these particular medications, you are going to carry out culture and you know, all those stuffs. So these are the examples of bacteria that causes meningitis. We have Streptococcus pneumoniae, Neisseria meningitidis. We have Haemophilus influenza, Listeria monocytogenes. Then example of viruses, I just listed. We have a lot of them, but I decided to list just few. We have enteroviruses, herpes simplex. Yes, HIV virus can also cause it, mumps. Varicella zoster, the one that causes shingles. Then lymphocytic choriomeningitis. Take note of this, please. Now let's talk about mode of transmission. Mode of transmission. All right, let's continue. So sorry, can you still see my screen? And can you still hear me, please? Someone say my slide is not bold. Is it applicable to everybody? Because I'm actually using a full full screen. So please check your own device. If you are using laptop, if you are using, maybe the person is using phone or something. Okay, so there's nothing I can do here. Thank you. So let's continue. So mode of transmission. So now let's take note that transmission occurs in area of high population density. When you have overcrowded, you know, in area that is overcrowded, like college dormitories and prisons. So let's be careful. That's why you say, okay, when you want to educate your patient, you tell them that they should avoid overcrowded areas, because there is high possibility that, okay, this infection, this particular meningitis you can actually contact it in area of what? Overcrowded area. Then it is usually spread through what? Through droplets means. Direct contact or droplets. So when a patient has meningitis, this is where your knowledge comes in, your knowledge of droplet precaution. So when you have a patient that has meningitis, you should know that as nurses, you are going to make use of what? Droplet precaution. And you know that droplets, the precaution you use for droplets is different from airborne. When you have two patients, one has airborne infection, another one has droplets. The precaution you are going to use for airborne will be totally different from the one you are going to use for droplet precaution. So meningitis is what? Droplet infection. So when someone who has meningitis coughs, when they sneeze, when they cough, when they talk, and droplet infection are usually a bit heavier than airborne. Airborne can travel miles. It can travel miles and not just land on someone's mucous membrane, and then if the person's immune system is already weakened, the person might have the infection. But droplets cannot travel far before it settles down because they are heavier than airborne. So when the patient that has meningitis, when they cough, when they sneeze, when they talk, they release all these microorganisms into the atmosphere and it settles. So when you have a patient with meningitis, you make use of droplet precaution. So now let's quickly deviate and talk about droplet precaution. So please, can you comment? What are the droplet precautions? So take for instance, now you have a patient who has meningitis in your ward. As nurses, please type. What are the droplet precautions you are going to maintain so that the patient doesn't infect other patients? Face mask. What type of face mask, please? Mask. We have different type of mask. What type? Someone says nose mask. No, it's not nose mask. Regular hand washing, thank you. Isolation, thank you. Please answer, what type of mask? Mask. There's no, N95, no, you are wrong. It's not N95. Surgical mask, thank you. You are using surgical mask. Thank you. Please, as nurses, let's take notes. Don't just say mask. We have different types of mask. So you use surgical mask for a patient with droplet precaution, surgical face mask. Thank you. Yes, you can make use of glove too. Fine. So, but N95 is used for what? Airborne infection. If a patient has tuberculosis, if a patient has measles, if a patient has shingles, varicella zoster virus, that's when you use airborne. You use airborne. So, but in a patient like this, you use surgical mask and you isolate the patient. Single room. So you don't put a patient that has meningitis, you don't nurse them. You don't nurse them by the side and screen them. It is wrong. So we actually look for what? We isolate them totally from other patients because it is a droplet precaution. And you have to protect your eyes, your nose. You use Google. Yeah, Google too. You have to protect your eyes. Google is part of our droplet precaution. Very, very important. Very important. I Google. Yeah, I Google. Thank you. So that is part of our droplet. Someone say immunization. Is immunization droplet precaution? No. So we are talking about our precaution as nurses now. So thank you. Can move forward. Apron, no, you don't need apron. Apron is not part of droplet precaution. So now let's talk about risk factors. We have talked about the causes that, okay, the patient's major causes are bacteria, virus, fungi, and them. So now let's talk about risk factors. What are the things that can predispose a patient to having meningitis? Predisposing factors. If someone has skull fracture or a surgery was conducted, maybe like brain or spinal cord injury, all this is exposing the meninges directly to infection. When the patient has skull fracture, when the patient undergoes brain or spinal cord injury, and adequate precaution or sterilization is not maintained, there is a way of actually introducing this microorganism directly into the CSF, and the patient will just have that meningitis for free. Then sinus or upper respiratory tract infection too can predispose the patient when the patient is using nasal spray, when someone has compromised immune system. when their immune system is weak and they cannot fight infection. Then HIV vaccine. Lack of HIV vaccine. Please, what is HIV vaccine? I probably will be able to cover 2 topics today. HIV, sorry. I want it to be an interactive class. That's why I'm asking question. So that when I set my question, you will not say it is difficult. Thank you. All right. So, Haemophilus influenza type B. So, this HIV vaccine, it causes a form of terrible respiratory tract infection, especially in children. This HIV vaccine, it can make the throat to swell up and a child will not be able to breathe. So, this HIV also has the capacity to cause meningitis. Then there is another one, is not in my slide, PCV, pneumococcal conjugates. So, let's take notes. Then cochlear implant devices. Cochlear implant devices. Then inner ear fistula or recent placement of ventricular shunt. So you notice that all these things that I mentioned there, apart from the vaccine, and they are more like invasive procedures that can actually expose the meninges to infection. So are we still together? Just a moment, please. So are we together, please? I hope you are following me. Okay, thank you. Sorry, my background is a bit noisy, but just bear with me because I have to come to a place where I can actually have access to uninterrupted network. So please, let's manage. Thank you. Now, let's talk about pathophysiology. There is no big deal in the pathophysiology of meningitis. No big deal. Meningitis typically occurs two true routes. It can be through, hematogenous seeding. Hematogenous seeding is the same thing as spread. It can be through blood. Then the second one is through direct spread. So what do we mean by hematogenous seeding? Bacteria colonize the nasopharynx and enter the bloodstream after mucosal invasion. So it is possible that, this bacteria finds their way through the bloodstream. If patient has like upper respiratory tract infection, or this bacteria actually colonizes the nasopharynx, then they find their way through the bloodstream. From there, they will go to where? Subarachnoid space. When they get there, they crosses the blood-brain barrier. And immediately they crosses the blood-brain barrier, what will happen? Someone's camera is on and you are distracting us, please. So please switch off your camera. Thank you. So they find their way to the what? To the subarachnoid space. And then it crosses the blood-brain barrier. So when it crosses the blood-brain barrier, it causes direct inflammatory response. So you know that the body has there is a way our body defends us, like a normal protective mechanism. So when microorganism finds their way into the body, the body will normally wants to defend it. So that is why we have this inflammatory response. And immediately this happens, what will happen? There will be inflammatory response within the meninges, and the meninges will become inflamed. The intracranial pressure will go up. So that is why patients start manifesting all these signs and symptoms that we'll discuss later. Then direct spread, organism can enter the CSF via neighboring anatomical structures. If a patient has otitis media, sinusitis, foreign object, I think I've actually explained that in the risk factors. That if a patient is exposed to all these invasive procedures that has to do with the hair, the brain, what's it called? The spinal cord, or maybe a patient wants to do a particular investigation and you need to obtain the CSF. You have to be careful. You can actually introduce this microorganism directly or during postoperative procedure. And immediately they find their way, they are going straight to what? To the subarachnoid space. From there, they cross the blood-brain barrier, they affect the meninges, and the inflammatory process takes place. Can I continue? Okay. So this particular diagram is just to summarize what I've just explained, just to make it very simple for you, so that, okay, you will know that, okay, this is how the pathophysiology goes. So please take time and study. It's very, very simple. So when this microorganism finds their way, an inflammatory process takes place, then this patient comes down with what? Increased intracranial pressure. Increased intracranial pressure. So let's go to signs and symptoms. Take note, the major signs and symptoms in meningitis is what? Headache. Headache. Patient has photophobia. They will not be able to withstand too much light. Knuckle rigidity. Then phonophobia. They will not be able to withstand noise. Then high temperature, because definitely inflammatory process is going on. Irritability, yes. Once there is intracranial pressure, the meninges is irritated. So this patient will start manifesting all these neurological signs. Due to increased intracranial pressure, the patient will have what? Nausea and vomiting. Patient will have chills, there will be nystagmus. Then in a child, in pediatrics, the signs and symptoms is a little bit different. There will be high-pitched cry. When the child is crying, it will not be a normal cry. If you have actually nursed a child with meningitis, if they cry, it's usually somehow on the high side. It's usually high-pitched. Then their fontanelles will be what? Will be bulging, because the skull of a child is usually smaller than that of an adult. So this accumulation of CSF, it makes it to be what? It affects all other features that are on the face. So this child will have bulging what? Bulging fontanelle, even their eyes, everything will be affected. So a child now will not be complaining of headache, but for an adult, the adult will have what? Headache. Then in adult, there will be agitation, there will be altered what? Level of consciousness. Patients can have seizure, coma, then lastly death. Now, what are the early signs of increased intracranial pressure? The first sign, when the patient has increased intracranial pressure, the first sign you see in your patient is restlessness, altered level of consciousness, restlessness, irritability. The patient will be agitated, and there will be decreased mental status. There will be decreased mental status. The mentation of the patient will be altered immediately. Those are the early signs of what? Increased intracranial pressure. Are we together, please? Please, all these things, am I making sense? Okay. So now let's go to how can we diagnose it? Now, how can you diagnose meningitis? The first diagnosis, it can be done by we nurses. Even before the doctor comes to carry out any form of investigation, when you suspect your patient has meningitis, the first thing you can do is to carry out physical examination. And this involves Koenig sign and Brudzinski sign. Koenig sign, Brudzinski sign. Now, what is Koenig sign? What is Koenig sign? You can see that Koenig sign is starting with letter K. It is starting with letter K. So the way I used to remember, I don't know if it will help you. When we say Koenig starts with what? Letter K. So K, knee, our knee starts with what? Letter K. So for Koenig sign, you should be able to ask your patient, you ask what will you do in Koenig sign for you to elicit or to actually detect if your patient is having meningitis. You ask your patient to lie down supine, facing up. So when the patient lies down supine facing up, okay, I think to make it easy, let me show you a picture. Okay, so can we see this picture? Please, just a moment. All right, please, can you see any picture? You should be seeing a picture now. There is a picture slide down. I want to use it to explain Koenig sign and Brudzinski sign. Okay, good. It's showing. Okay, thank you. It's showing. Okay. So Koenig sign, the lower one is the Koenig sign. Like I said earlier, that knee starts with letter K. So when you can see that this person is lying supine, now you will flex the patient. You ask your patient to flex their knee. Can you see that? Okay, the hip and knee is at the angle 90 degree. So if this patient is positive to Koenig sign, the patient will elicit pain. Can you see? Elicit pain or limited extension. The patient will feel a terrible pain. Patient will not be able to achieve this. So as you flex the knee, you do as if you want to extend it, and this patient will elicit a terrible pain. I don't know if I'm making sense. I don't know if I can describe it better than that. That was why I looked for the picture and then so that you can have a better understanding. So the patient will elicit, as I'm trying to extend, the patient will elicit a very terrible pain, and that means the patient is positive to Koenig sign. Patient is positive to what? Koenig sign. Then the other one is Brudzinski sign. The patient is still lying supine, but you ask the patient to you raise the patient's head. You do as if you want to flex the patient, to support the patient's chest with one hand, and you flex the patient's head with the other hand. So the patient responds by flexing their knee. You know, the patient was lying down supine initially. So this patient will respond by what? By knee and hip flexion. The patient will not be able to, immediately you flex their head, the patient responds by flexing their own knee and hip. And that means they are positive to what? Brudzinski sign. Am I communicating, please? Okay, gotten. So we have gotten it. All right. Someone say I should repeat. Please, for the last time, I will repeat it. I said Koenig sign has to do with what? Do with the knee. I said K. The way I used to remember, letter K starts with knee. Ask your patient to lie down supine, facing upward. Flex the hip at the knee. Make sure they are at the angle 90 degree. Do as if you want to extend the knee. The patient will elicit terrible pain. So immediately you try to extend the knee beyond 135 degree. You know, already you have maintained a 90 degree. If you look at this picture very well, we are maintaining an angle 90 degree. But immediately you try to extend, like, okay, you want to go beyond 135 degree, the patient elicits a very terrible pain. Or the patient can even tell you, oh, I'm having terrible back pain. The patient will not be able to extend that leg. You'll not be able to, that extension will not be achieved. So that shows that this patient is what? Is positive to Koenig sign. It is a sign that this patient is having meningitis. You know you are carrying out, you've not done any lab investigation now. Then the Brudzinski sign, patient is still lying down flat. Now raise the head of the patient. Immediately you raise the head of the patient will respond by flexing their hip and knee. That is positive Brudzinski sign. So those two signs are enough for you as nurses to diagnose that your patient is having what? Neuromeningitis. No, now let's go to nursing intervention. We have talked about droplet precaution before. Isolation, you isolate the patient from all other patients. It is a taboo to keep a patient that has meningitis with other patients. Before you know it, you infect other patients. Then, okay, sorry, I think I'm not done with the diagnosis. Sorry, let's go back to diagnosis. So now, CT scan. Another way you can diagnose is CT scan, and this should be done before lumbar puncture to prevent brain herniation in case if a patient has increased intracranial pressure. So that CT scan is done before lumbar puncture to prevent brain herniation in case the patient is having ICP. Now, let's talk about lumbar puncture. As nurses, this lumbar puncture, you're supposed to know your nursing responsibilities before, during, and after. If your patient is supposed to go for lumbar puncture, there are nursing responsibilities before, during, and after. Please know it. So lumbar puncture now, they are going to obtain a sample of cerebrospinal fluid. So they are going to obtain a sample of cerebrospinal fluid in this patient because we don't know if this is caused by what? Bacteria, virus, or fungus. We want to know. I told you earlier on that bacterial meningitis is the most common. So now when they now obtain the sample of CSF, there are things to note in a patient that has bacterial meningitis. The key things that they are going to note if a patient has viral meningitis or bacteria will be different. So now let's listen. If a patient has bacterial meningitis, the CSF, the normal color of CSF, you know it is clear. Like, why will I put it now? Is it crystal clear or is this clear? It has no like a particular color like that. So now, if they now obtain that sample of CSF and they now analyze it in the lab, for a patient that has bacterial meningitis, this cerebrospinal fluid will be cloudy. It will be what? It will be cloudy. You know, this cerebrospinal fluid had their normal components before. It has glucose, it has protein, we have white blood cells. So now, the protein content and the white blood cell will be elevated. I didn't put all these in my slide because I don't have the time. So just take note that the protein content will be elevated beyond normal. The white blood cell count will be excessively elevated. The glucose will decrease. There is glucose in the cerebrospinal fluid. You know, I told you that it is this CSF that nourishes the what? The brain and spinal cord. So we have glucose content there. But the glucose will decrease. The color of the cerebrospinal fluid will be what? It will be cloudy if it is caused by bacteria. And there will be gram-positive stain. The bacteria will test for what? Gram-positive. It will be test for gram-positive stain. Please, am I making any sense? If it is bacterial meningitis, these are the things you are going to see when they analyze the cerebrospinal fluid. Is it clear? Now, for the virus, the color will not change. It will be clear. So if it is viral meningitis, the cerebrospinal fluid will be clear. It will be clear. The white blood cells and the protein too will increase, but not like the bacteria, just like slightly elevated. Unlike bacterial meningitis, whereby the whereby the protein content, the white blood cell content will be excessively elevated. And it will what? It will test for gram-negative. And the color of the cerebrospinal fluid will remain crystal clear. It will not be cloudy. So can we move on? Please, let's respond. All right. Then a blood test can also be done to check for bacteria, viruses. Now, nursing intervention. Like I said, let's maintain our droplet precaution. Then initiation of antimicrobial therapy. After sample of CSF for culture and sensitivity, you have to maintain hydration and ventilation. Reduction of ICP. These patients are prone to what? Intracranial pressure. So we have to make sure that, okay, you don't do things that will make this the intracranial pressure to increase the more. like elevating the head of the bed. You want to raise the head of the bed a little. You have to minimize the way the patient coughs, things, anything that will increase intracranial pressure, you have to do it. You have to tell the patient to do away with it, because we don't want anything that will cause further harm or damage. Then you manage systemic shock. This patient is having infection, so definitely the patient is prone to shock. Then this patient, because of the neurological manifestation, the patients are prone to having seizure. So you control seizure, you control their temperature, you maintain seizure precaution. When we were doing seizure last semester, we talked about seizure precautions. Then fluids are given directly into a vein to prevent dehydration. Oxygen through a face mask if there are any other breathing difficulties. This patient can be given anticonvulsants too, because if they're having seizure regularly, they can be placed on anticonvulsants. Steroid medication to help reduce swelling around the brain. The brain is swollen. Please, can you hear me? Because my network has started. Yes, bacterial meningitis. Yes, I said it. Be positive for gram stain. Yeah. Please, can we see my slide? Okay. So now you nurse your patient in a very quiet room. Nurse your patient. You don't nurse this type of patient now at the nursing station. If an applied question comes on that okay, so Mr. So and so, okay, has meningitis, age, this particular one, and you have an applied question on it, that okay, nurse by the side of the ward, nurse at the nursing station, or put directly in front of the nurses, so that I will frame the question in such a way that it will be so enticing, you will think it's the right question. So now you say, okay, put the patient in front of the nurses so that they can actually monitor the patient well. And another one option says isolate the patient. So you know that you're not going to pick the one that says you should nurse at the bedside, or in front of the nurses, so that you can actually monitor the patient properly. So you nurse the patient in an environment that is quiet. You make sure that the light in the room is dim. You don't nurse the patient, you don't turn on all the lights in the room. And this one will start irritating the meninges, and the patient starts being irritable. So you put on a dim light. You drop the curtain. You don't want anything that will make the patient to be what? To be irritable. Now, these are the measures to take to prevent what? Increase intracranial pressure. Avoid any form of coughing, sneezing, no bending of extremities. So anything that will actually put a pressure, increase intracranial pressure, you make sure that, okay, you prevent your patient from doing that. Then you raise the head of the bed at least 30 degrees. Raise the head of the bed at least 30 degrees. So all these measures are done to actually what? Reduce intracranial pressure. So these are the likely complications when a patient has meningitis. 1 in 5 people surviving an episode of bacterial meningitis may have long-lasting after effects. If this is not well managed, if it is not well combated, this patient can have hearing loss. They can lose their sense of hearing for life. This patient will keep having repeated seizures because the brain has already been damaged. Limb weakness, difficulties with vision, speech, language, memory, and communication. How can you prevent it? You can prevent it by vaccination. Vaccination, very, very important. So as nurses, you educate your patients, let them take vaccine to prevent all this. Or you have someone that is traveling to an area of overcrowded, an area that is overcrowded, they should have this what? They should have meningitis vaccine. Very, very important. Vaccinations include Haemophilus influenza type B, pneumococcal conjugate vaccine, pneumococcal polysaccharide vaccine, meningococcal conjugate vaccine, serogroup B meningococcal vaccine. Washing of hands frequently, especially before eating, or anytime you come in contact or maybe as nurses now, hand is part of our hand washing is part of our universal precaution. We want to assume all patients are what? They are infectious. Before you touch your patient, after, or maybe within, anytime you have contact with patients, sometimes you are caring for this patient, you are touching the bedside table and all those stuff. Hand washing has to be part of us. Educate your patient, they should wash their hands too frequently. Avoid close contact, no sharing of cups, utensils, toothbrushes. Any questions so far? Okay, someone said I was breaking. Is it applicable? Can you hear me? I'm not sure if there is post-exposure prophylaxis. I don't know. Any questions so far? Any questions so far? Any question? The glucose level in viral meningitis, the glucose level might be normal or just a slightly elevated. Yes. But in bacterial meningitis, the glucose level will be low. I think I've forgotten the reason why the glucose level is low actually. Oh, please, we are all senior nurses, so let's do further reading. Okay. So can we continue with the class? I'm done with meningitis. I would love to take another class. Or you are tired. If you are tired, we can have the class another time, or I will record. Should we take another class now, or we should close? It's just a moment. Okay, someone was trying to ask a question, and unfortunately, I can't. What else? Okay, let me. One of the ways to reduce intracranial pressure, yes, is to raise the head. Yes. Any problem about that? Yeah, you raise the head to 30 degrees. Yes. If your patient is lying flat, the intracranial, that you are actually adding more pressure. Ma, it's our time for prayer. Okay. Okay. So some people say we should close the class. That they're having. Should we consider? Because I want everybody to benefit. Okay, I think a lot of people want us to continue the class. Okay. Okay, so many people want us to continue. So let's go to another topic. So others can watch the recording. Thank you. Because you don't have time. And unfortunately, I am busy. I might not be able to schedule another class. And if I record, well, the recording will not, I will not take my time to explain like this. I will just record, and you figure out the rest. So let me share another slide. Okay, share another. So can we see my slide now? What can you see on the slide? Please tell me, what can you see on the slide? I actually gave you this topic last semester as an assignment, but I was not satisfied with the response or with the assignment. Okay. So I actually decided to take this topic because it is related to spinal cord injury. And I feel like spinal cord injury, we are all professionals and we are experts. So spinal cord injury is not a big deal for us. It is not big deal. In fact, there is nothing there. So it is something we know very well. And we can just read and understand. So that was why I didn't bother myself. But this one is a less common topic. It is not usually discussed. And we need to know it. So it is part of, someone is saying which study section. It's not in your study section. It is not, but it's a neurological disorder. So it is a neurological disorder. So let's take note. Okay, so can we see the full screen now? Can you hear me? Can you see the full screen? Okay, so let's quickly rush through it. Okay. Now, what do we mean by autonomic dysreflexia? So last semester, when we were talking about neurological disorder, we said that, okay, the nervous system is divided into the what? The central nervous system and the peripheral nervous system. So the peripheral nervous system, under we have what? The somatic, and we have the autonomic nervous system. Under the autonomic, we have sympathetic and parasympathetic nervous system. That is how the division goes on and on. So now, from the word autonomic dysreflexia, when we are saying autonomic, that means it has to do with what? Autonomic nervous system. So usually we'll be talking about sympathetic, and what made up the autonomic nervous system is the sympathetic and the parasympathetic nerves, which is beyond our control. We don't have control over it. That is why we are calling it autonomic. It is beyond your control. You can't do anything about it. So now, what is the definition of autonomic dysreflexia? You can also call it hyperreflexia. Autonomic dysreflexia is exaggerated reflex response by the autonomic nervous system. Exaggerated reflex response. When their reflex response is exaggerated beyond normal, due to an irritating stimulus below the site of spinal cord injury, and it is a serious medical emergency. It is a serious medical emergency. Now, when we are talking about sympathetic and parasympathetic nervous system, take a look at this picture. Can we see this picture? Please, what can you see on the slide now? Can you see my picture slide? Please, let's always respond quickly so that I can know. Oh, good. You can see. Thank you. So now, the sympathetic nervous system and the parasympathetic, they are under what? Under autonomic nervous system. Now, sympathetic and parasympathetic nervous system, they work together. They are partners. They are partners. They have business together. They work together. But even with the fact that they work together, they work opposite each other. I don't know if I'm making sense. They are actually working together, but their own action are opposite each other. If parasympathetic is going up, sympathetic will be coming down. So they oppose each other's action. And that is exactly what we want. We want them to oppose each other's action. By the time parasympathetic nervous system and sympathetic, by the time they start unopposing, if it is unopposed, then we have a problem. They have to what? Continuously oppose each other. Because if they don't oppose each other's action, then the body's homeostasis will not be maintained. Now, look at this parasympathetic nervous system. I remember last semester, I told you that in parasympathetic nervous system, I was talking about what? The cholinergics. Parasympathetic nervous system is for rest and digest. While the sympathetic is for fight and flight response. When you are in danger or when something is wrong, it is the sympathetic nervous system that will bring about the release of adrenaline, that will tell you to fly, that will tell you to run away, there is danger, that will communicate it to the brain that, oh, there is a problem, you need to run. It will cause your pupils to be dilated so that you can actually see, so that you don't go and jump into where you're not supposed to jump to. Your pupils will be widely dilated so that you can see clearly. Your airways will be dilated. You have bronchial dilation so that you can take in more air, more oxygen. You need to breathe. Your heart rate will increase. Or don't you notice that when we are scared or there's a problem, your heart rate just, it keeps pounding. It is the work of the sympathetic nervous system. It inhibits digestion. It causes what? Vasoconstriction. And your blood pressure goes up. It is the work of sympathetic nervous system. So now let's just imagine if it is only sympathetic nervous system that is working and the parasympathetic nervous system is doing its own and is just looking. What do you think will happen? Blood pressure is consistently up all the time. The heart rate is up all the time. Your pupils are dilated all the time. Your salivation is decreased all the time. What do you think will happen? Please let's respond so that we can understand. You are not responding, no. Death. Okay, someone said death. Fine, yeah, the person will die. Okay. There will be imbalance, coma. Yes, so there will be trouble. There will be serious trouble. In fact, before you know it, the person will go into seizure. And before you know it, the body will wear out and the person will die. So as the sympathetic nervous system is doing all this, the parasympathetic is working to calm it down, to say, hey, I think we have enough of that. Exhaustion, thank you. Shutdown of the system, thank you. So the parasympathetic nervous system is now saying, I think we've had enough. It is that parasympathetic nervous system that will now regulate it. That, okay, enough is enough. I think it's okay now. So the parasympathetic nervous system will gently, will regulate the work of the sympathetic. And if the parasympathetic nervous system too is doing too much, is my voice breaking? Someone say my voice is breaking. I don't want my voice to break. Oh. Please check your network. Please let a lot of people respond. Can you hear me? Is my voice breaking? No. Okay. So if the parasympathetic nervous system too is doing too much, the sympathetic will quickly call it to order. So that is why they work opposite each other. They work together. Can you see that they are partners? They work opposite each other. So they work to maintain, to keep a body in check, to make sure that our body is what? Is in balance. So that we don't die before our time. So that is why parasympathetic and sympathetic nervous system must work together. Immediately they start working on their own, then we are in trouble. So that means parasympathetic is doing its own. Sympathetic too, they are doing their own. They are no longer what? They are no longer in partnership. Then there is a problem. That is what I'm trying to explain in this my slide. So now what happens in autonomic dysreflexia? Autonomic dysreflexia is very common in patients. It is not a disease that just happens magically. No, it can't happen by itself. It can't happen by itself. When the patient has spinal cord injury, when the patient has spinal cord injury above the level of what? Look at this diagram. Above the level of T6. You know, we have the cervical, the thoracic, the lumbar, and you know all those stuffs. So when a patient has spinal cord injury, maybe for a long period, the patient has sustained spinal cord injury as a result of road traffic injury, RTI, or what do you call it? Or something just happened. And that injury is now at the level of what? T6 and above. If the patient has spinal cord injury below, we have no problem. The patient cannot have autonomic dysreflexia. You have no business with worrying yourself about a patient that sustained spinal cord injury below the level of T6. But if a patient has spinal cord injury from T6 and above, that patient is likely to have autonomic dysreflexia. Can you please increase your voice? I don't think anything is wrong with my voice. I don't think so. Please, let's comment. Please, let's comment. So, is it the person? Maybe it's the person's network. It's a network. All right, thank you. It's a network. So if a patient now has injury around that T6 and above, this patient is prone to having what is called autonomic dysreflexia. And why? Why do they have it? Now, we have talked about parasympathetic and sympathetic nervous system, that they work together, even though they oppose the work of each other. They work together, but they oppose the work of each other. Now, what will happen is that in a patient that have injury around T6 and above, if there is anything, if there is no irritation, if there is anything that is causing irritation below the level of the injury, it can make the patient to have autonomic dysreflexia. That is where we are now going to go back to the causes. Because it doesn't just happen on its own. Now, look at these causes. We have bladder. Bladder. I definitely put it that way so that you can know that any issue that has to do with bladder. If a patient has full bladder, a patient that has spinal cord injury above the level of T6 and above, that has it from T6, if that patient has full bladder and is not empty, it can cause a form of what? Irritation. There will be, signal will be sent. Normally, like in a normal human being now, in a normal person who doesn't have any problem, You know, when your bladder is full, you know, something will tell you that your bladder is full. You need to go and empty it. The enough signal will be sent to the brain that, oh, my bladder is full. I need to go to the toilet. And there's no problem. But in a patient with spinal cord injury from level of T6, if they have a full bladder or they have urinary tract infection, anything that can just cause a form of irritation, you know, that nerve signals, immediately it's sent out. It will not be able to cross that level of injury. You know that they communicate together. They work together. So immediately that nerve signals get to the point of what? To the point of the injury, it will be blocked. That signal will not be able to get to the brain. Am I making sense? That signal will be blocked. Yes, the signal will be blocked immediately. It will not be able to cross. Or if a patient has bowel impaction, a patient has skin breakdown, or maybe the patient has pressure ulcer or pressure injury, or there's anything irritating the skin, or although take note, the major cause that can actually bring about this problem is full bladder. Please, let's take note. The most common cause is the full bladder. That is the most common cause. Then bowel impaction, fecal impaction, breakdown of skin. Other miscellaneous causes are pregnancy, menstruation, sexual intercourse, or tight clothing. They are miscellaneous causes. They are not a major cause. They can actually trigger it, but they are not. But the major cause is full bladder. Full bladder. So immediately that nerve signals gets to the point. So can you see this picture now? Immediately now you can see nerve signals are blocked at the what? At the spinal cord injury. It will now cause what? You know, the sympathetic nervous system is in action there. The sympathetic nervous system is in action below that level of injury. So immediately nerve signals is not able to cross the point of injury. Kí ló máa ṣẹlẹ̀? What will happen is that it will cause, there will be excessive what? Vasoconstriction. There will be excessive vasoconstriction. Now I told you sympathetic nervous system is responsible for what? Vasoconstriction. So there will be excessively high level of blood pressure. So you can see that nerve signals are blocked at the spinal cord injury, causing blood vessels to tighten. And there will be what? Excessively high blood pressure. Do we understand to that point? Okay. So it will bring about a form of what? Vasoconstriction. So immediately there is that vasoconstriction, then the baroreceptors will sense it. They will sense it. There is a sensor, there are baroreceptors in the blood. They will sense it that, oh, there's a problem. They will sense it that, oh, there is a problem. They will send the signal to the brain. You know that signal is not able to cross, but these baroreceptors will help. It will detect hypertensive crisis, and the brain is what? Signal. Immediately the brain is signal, the brain will want to involve the sympathetic nervous, parasympathetic to actually do what? To actually help in calming it down. But unfortunately, it cannot cross the level of the injury. So the parasympathetic is doing its own upward above the level of the injury. The sympathetic is also doing its own. And there is what? The patient is thrown into crisis. So there will be massive what? Sympathetic response below the site of the injury. Simply because there is irritation of the bladder. Maybe the bladder is full, there is fecal impaction, or patient has urinary. This is the thing that will cause that irritation. So now, it will make this thing I just explained now, we make the signs and symptoms to make sense to you, so that you not just cram it. Because it's like what I just finished doing is pathophysiology. I have finished describing the pathophysiology. Someone say I should recap. I say autonomic dysreflexia does not just happen magically. It usually affects patients with spinal cord injury. Autonomic dysreflexia doesn't happen in a patient without any spinal cord injury. But that spinal cord injury is peculiar. It is peculiar to T6 and above. When that injury is at the level of T6 and upward, that is when a patient can have autonomic dysreflexia. And it is something that will trigger it. When you know that you are managing a patient that has injury at the level of T6, and that patient now has full bladder, you wouldn't want to joke with emptying the urinary catheter of such a patient. The patient wouldn't want to joke with, you wouldn't want to joke with that patient having full bladder. If such a patient has full bladder, if such a patient has UTI, the patient has fecal impaction, or there's a pressure sore, or the patient has been mismanaged, the patient developed pressure sore, this can trigger what? It can trigger exaggerated sympathetic nervous system response. It can trigger it. Because immediately that nerve signals wants to go to the brain. It will not be able to pass the level of the spinal cord injury. It will not. It will stay there. So, and by the time it stays there, there is excessive or exaggerated sympathetic response, which leads to what? That was why I took my time to explain the work of sympathetic and parasympathetic. So sympathetic nervous system, we all know that it's for fight and flight. So that sympathetic nervous system will bring about exaggerated response. There will be excessive vasoconstriction below the level of the injury, and patients will have what is known as hypertensive crisis. Vasoconstriction will happen, and the parasympathetic nervous system cannot also come and help us. It cannot come and help the sympathetic. It cannot cross. Their connection has been what? It has been broken. Their connection has been blocked. Their connection has been severed. So both of them can no longer communicate. The sympathetic nervous system is doing its own below the injury. The parasympathetic is doing its own. So, but when there is that hypertensive crisis, the baroreceptors will sense it and will help to send the signal to the brain. But unfortunately, there is little or nothing that can happen. So now, let's look at the nature of the blood pressure. Now, hypertension, the systolic is usually 20 to 40 milliliter higher than baseline. So it's not the normal, this one has nothing to do with the normal baseline. The normal range of blood pressure is between 100. It has nothing to do with that. Because sometimes, if your patient has 140/90 or 130-something, 80-something, you might be thinking that, this blood pressure is still okay now. It's still within normal range. We have some patients that their normal blood pressure is like 90/80. So take, for instance, now I've put it in my slide. Your patient comes in with 106/78. And now the patient is having 146/92 in a patient with spinal cord injury above the level of T6. Then you should start suspecting that this is no longer normal. This patient there's something going wrong. There's something going on. Something is wrong. Please, am I making sense? So it's not until you start seeing blood pressure of 200, 220, 220, 200, or 180, 150. That's not what we are saying. Am I making sense? Our normal belief is that, okay, when we are talking about hypertensive crisis, that means that blood pressure should have shot up really. No, the blood pressure doesn't have to go as high as that. Immediately there is just a slight change, like 20 to 40. You start suspecting it. So it is your patient's baseline blood pressure that matters. It's your patient blood pressure baseline that you are going to use to determine. So immediately you are having that difference, then you should know that in a patient with spinal cord injury above T6, then there's a problem. Another thing is throbbing headache. Throbbing headache. This patient will be complaining of what? Throbbing headache. And why is this patient having throbbing headache? The parasympathetic nervous system, it causes what? Vasodilation. There is excessive vasodilation above the level of the injury. The patient is having vasodilation. There is excessive blood supply to the brain, and everywhere is crampy. Everywhere is choked up. This patient will have throbbing headache. Patient will have flushing. Flushing. Why is the patient why do you think? Okay, so that I can know if you actually understand. Why do you think the patient is having throbbing flushing above the level of the injury? According to what I've explained, why will the patient have flushing? The patient's face will be flush. Why? Who can actually tell me why the patients will have flushing? I hope we understand the meaning of flushing. We'll know it. Who can try? Who can try? I want us to respond. If you want to talk, can you raise your hand, please? Why do you think the patient will have flushing? Nobody wants to try. If you want to try, we'll mute you. Okay. If you feel you can't talk, what about typing? Just try. Okay. Are we responding? Thank you. Because of vasodilation. Excessive vasodilation. Thank you. Excessive vasodilation. Because of increased BP. No, it's not because of increased BP. It is not. Yes, because there's vasodilation. Thank you. There's vasodilation. And why do you think the patients will have pale, cool, and clammy skin below the injury? Please, let's respond. Why would the patient have pale, cool, and clammy skin below the injury? Shock, no. It's not because of shock. Why? Parasympathetic effect, no. Thank you. Because of vasoconstriction. Thank you. Because of vasoconstriction. So, see, by the time you have a deeper understanding of your sympathetic and parasympathetic nervous system, you have no problem with this topic. Just go and know what the work of sympathetic and parasympathetic is. You see, you will just be, all the signs and symptoms, you just keep coming without you having to read or something. Once you just understand the action of sympathetic and parasympathetic nervous system, you will actually supply all the signs and symptoms directly from your brain without having to read excessively. So it is because of vasoconstriction. This is why we're having, I told you that there will be vasoconstriction because of the sympathetic action. The blood pressure will go up. So definitely the skin too will be pale, cool, and clammy. That is just the simple thing behind it. Now there will be bradycardia. There will be bradycardia, excessive bradycardia, below 60 beats per minute. Patients will have bradycardia. So we should know that this bradycardia is the work of what? It is the work of parasympathetic nervous system above the level of the injury. So your patient will have bradycardia, there will be piloerection, there will be diaphoresis. So can you see? You can see that we are having opposing, we can see that patient is having piloerection. At the same time, patient is having diaphoresis. You can see that the signs and symptoms are actually weird. They are weird. Because normally I will be like, how can someone be having piloerection at the same time sweating? Does it make any sense? So that is why you can see that a patient is having piloerection. At the same time, the patient is having diaphoresis. Because, the work of sympathetic and the connection has been severed. There's dilated pupils, there's stuffy nose, there's anxiety. So now let's talk about what? Nursing intervention. Let's start with prevention. How can you prevent it? If your patient has spinal cord injury. So what can you do to prevent this autonomic dysreflexia? The first thing is bladder. And I told you bladder bowel breakdown. So what are the things you will do? For bladder, you keep the bladder empty, assess urinary output, routine bladder scan, prevent UTI, use anesthetic jelly if needs to be catheterized. You don't want to do anything that will actually what? That will cause that irritation. Assess Foley catheter for kink or blockage. For bowel, check for impaction, assess bowel sound, palpate for distension, assess last bowel movement, use anesthetic agent for stool removal. For skin breakdown, remove any binding devices, anything that can cause skin breakdown. Reposition every 2 hours, assess skin regularly. Remove anything that will cause irritation to the patient's skin. So, nursing intervention now. Always assess blood pressure and monitor for elevation of systolic. 20 to 40 millimeter mercury more than baseline. If a patient reports headache, check BP immediately. We call the rapid response team if symptoms are present. Get help because it is a medical emergency. Position patients at 90 degrees with their legs lowered. Assess BP every 2 to 5 minutes. Remove binding devices or close clothings. Inspect the 3 big Bs that I just told you now, like their bowel, bladder, breaking down of skin. So that, okay, you know that, okay, hope it is not the bladder that is full. Is the patient having any form of skin breakdown? Does the patient have any form of ingrown toenails? Then you administer the prescribed nifedipine and nitrates, nitroglycerin paste or sublingual nitroglycerin. So these are the things you are going to do. Any questions so far? Thank you for listening. Thank you for your time. Any question before we call it a day?
Good afternoon, ma.
Good afternoon.
Ma, please, I want you to lay more emphasis on the one you were trying to explain to us about what causes was it the lowering of BP also?
Can you come
Or
again?
this
I don't understand your question.
That's what causes the BP? What makes the BP to be low, extremely low? In this case, in this condition of autonomic this. When you were explaining, I didn't get it well.
I didn't say, did I mention that BP will be low at any point in time? No, I
I
didn't say
didn't
that.
get it well, sir. Maybe you can just help me.
I didn't say anything about BP will be low. I said there will be excessively high blood pressure.
Okay.
Excessively high blood pressure because of the
Blood
fat
pressure.
vasoconstrictive effect.
Okay.
BP will be very high
High.
because of the exaggerated sympathetic response
Okay.
below the level of the injury. And unfortunately, the parasympathetic nervous system that is supposed to help to lower it cannot cross the level of the injury. The signal is supposed to get to the brain and let the brain know that, okay, there's a problem. The bladder is full. Okay. Unfortunately, that signal cannot cross the level of the injury. It stops there. Now, it is the baroreceptors that will help. But even though the baroreceptor is sending this signal to the brain, there is nothing that can be done because the parasympathetic nervous system too cannot also come and help. It can't do anything. So the parasympathetic nervous system will be doing its own. That vasoconstrictive effect is still there.
Okay, ma'am.
So they are both doing their own. So there is that exaggerated response below the level of the injury. And the patient BP will be very high.
Very high. All right. Thank you.
You're welcome. Says.
Actually, I want to Brother, help me on the agenda. When Mr. David is waiting for me, I want to sign this paper, I beg. Can I go ahead, ma?